Dr. R. Deuk here with Lori Schallenbach, our Director of Nursing. And we're getting ready to do a Deuk laser disc repair with a spinal cord stimulator removal on a patient who's traveled from North Carolina, I believe. We're located in Florida, so they've come a few states over to have the Deuk laser disc repair procedure done. And as usual, we're going to broadcast, but we don't share names or anything. Now, our patient has had chronic back pain. Really, on examination, it localizes to the L34, L45 region. The patient's had prior surgery a couple of times, not here, elsewhere. And I think they went to laser spine at one point, is that correct?
Yes, sir.
Yeah, they went to Laser Spine Institute for 2 surgeries, and then they had a spinal cord stimulator placed. And they have their stimulator off. They're here for their surgery on their back. We're doing the Deuk laser disc repair. Their disc herniations are not big. They're small, but probably grade 3 tears. Good morning. Why does the head and chest... No, we can't do that. I'm going to need you to lay flat, lay down on the table. What is it?
You feel that one that you need to go walk to the restroom?
He has to go to the bathroom?
That's what he feels like.
He went before we came back.
Yes.
All right. Well, he can just pee on the bed, right? Worst case.
We can, are you going to get like a...
You weren't drinking water or anything, right? All right, we're going to get started, okay? You're going to be fine. Just lay still, and before you know it, we'll be done. If you have to pee, you just pee, no problem.
They will clean you up.
All right. So you're going to feel a little stick and burn. We've already done our timeout. Yeah, that's normal, okay? Don't worry, everything's all right. So, for those of you watching the surgery, this is live spine surgery. You okay? Try not to move, all right? And with live spine surgery, you know, you as the viewer are gonna experience everything that we typically experience or can experience, maybe not even typically, but everything that we do experience during the surgery. So you're going to see the common and usual, and you're going to see the unusual and rare. All right, that's just numbing medicine I'm putting, okay? If you feel any pain, you just let me know. So we're going to be using X-ray machine to take pictures. Everything's okay, don't worry, you're doing fine. Shot. You got too narrow there. All right, let's go lateral. So our patient is laying on the operating table. He's awake. All of our patients are awake for lumbar when we're doing the lower back in the beginning. Of course, that's going to change soon. All right, I need to see the sacrum, of course. I can't count without seeing the sacrum. So don't even stop until you have a sacral view. All right, so seems like we're a little bit on the higher end. We're definitely doing 4, 5, and 3, 4, right? All right. Local. You should have things ready. Try to stay ahead of me. You're doing all right. That's just some numbing medicine. Stop moving your body, okay? It's not helping. Just let me know if it's uncomfortable for you. Huh? All right. Understood. Just do your best. I just need you to try to be still. We're going to get this done. Come on, Luis. You got to be watching me and knowing what my next move is going to be based on your experience. That's what I'm talking about. Shot. AP. Yep. Think about what I'm going to do next. That's how you become really good at assisting. All right, so that's better. Let's go back to a lateral. So we're kind of right in the middle of 3-4 and 4-5. So the first goal here is to get into the disc space with a transforaminal approach. All right? Having a hard time with this leg here. I mean, I don't know why we do that every time. It should be across the center and then back over. Luis, that's you. All right? Right here. I want to see this whole area. Thank you. Is that my shot right there? All right. Huh? I'm going for 3-4 and 4-5 first. Shot. Shot. Don't move. Shot. 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 Let's go with an AP. Okay. Thank you. Back to a lateral. Shot. Lateral. It's interesting. Spine is pretty anterior. Are you comfortable? He said yes. Oh, we should have a ray tech close by. It's virtually the same path I just infiltrated. Shot. 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 AP. Is he rotated at all? It looks like he's pretty flat to me. You're good on the AP. I don't need you to go all the way up. I just need to see where I'm at. All right, good. Lateral. So we're pretty close to the 4-5 disc where we need to be. I like our APN lateral views. Shot. Yeah, his anatomy is quite interesting. Shot. AP. It's right there. Shot. Lateral. We're going to keep you awake for the first 10 or 15 minutes, then we're going to put you to sleep, okay? You didn't drink anything for breakfast, right? All right. Shot. It's very strange. All right, we're not seeing the disc straight across. You need to wag it till we get the end plates flat. Because I'm hitting bone, but I don't see it on the lateral. So we must be hitting the top edge of 5 and not seeing it. Nope, other way. But it does look like we're hitting the top edge of 5 there. Yeah, that's what we're doing. It's got quite a bit of facet arthropathy. Shot. Interesting. Shot. Are you comfortable? This is the hardest part for you, and actually for me too. But we'll get there. This is the trickiest part, and we need to make sure we do it just right. You let me know if you feel anything, okay? Shot. All right, AP. So we're in the disc at L45, and now we're going to go 3-4. And this is where his pain is localized to. When I saw him in clinic, that's perfect. Stay where you are. So I believe if we fix at least these 2 discs, and quite possibly L23, well, we're going to test L23 to see if it's painful. Then I think we're going to get rid of his pain in his back. That's what I expect. That's it. Good job, Luis. Shot. So I'm going to aim for the 2-3 next. What is it? Shot? Yeah, thank you. Yeah, you want to line the end plates. All right, let's go to a lateral and see where we are. So if you're wondering what are the layers we're passing through here to do the surgery, we're passing through the skin on the outside, which is no big deal. Then we're passing through subcutaneous fat, which is, you know, every patient has different amounts of that. Shot? Then we're passing through something called fascia, the lumbosacral fascia. Shot? Yeah, that's better. And then we're passing through basically muscle. Shot? And then we pop out of the muscle and we're right at the foramen. Huh? Where do you feel it, AP? Just lay still. Where do you feel it? Yeah, not down your leg, right? Perfect. That's what we want. Yeah, that's great. Lateral. So really the things we're passing through to do the surgery are all structures that are easily healable. They heal easily. They really can't be damaged. They really can't cause problems for the patient. Like if we were going next to a blood vessel, like we do in the cervical, I need that wagged. You know, like in the neck, when we do the Deuk laser disc repair, we're passing the carotid artery, jugular vein. Those are structures that could be easily injured. Lay still, you're doing great. Very odd. I mean, is herniation really that big? Shot. That's a huge herniation there. That's impressive. All right.
We
You
have
have a question there?
we do. We have a viewer who says, "I have several herniated discs. Would this surgery be able to help?"
So one of our viewers says, I have several herniated discs. Would this surgery be able to help? The answer is very likely yes. And why am I not saying yes enthusiastically? So for whoever the viewer is that asked the question, one of the most important things we do in spine surgery or spine care is to figure out where your pain is coming from. And just because you have a herniated disc, I'm going for 1-2. Sorry, 2-3. I apologize. I meant 2-3. Just because you have a herniated disc or 2 or 3 does not mean that they're the cause of your pain. And if you understand that concept, then you've already understood so much more than most people. Everyone thinks that they have back pain. They get an MRI. The radiologist says herniated disc. They think that that's the cause. Most of the time, herniated discs are not the cause of back pain, even though you might have them. The most common cause of back pain is the facet joints, spelled F-A-C-E-T, shot. And the most important thing your doctor will do for you is figure out if your facet joints are the cause of your pain or not. So I can tell you, most of the time the facet joints are the cause of pain, even though you might have a herniated disc. Shot. Yeah. Oh, I may need to be more lateral. His facets are, his anatomy is very different. It's a lot of lateral, really lateral facets, forcing me to start more lateral. So if your herniated discs shot are the cause of your back pain, then the answer is yes, certainly. This is the best surgery in the world for your herniated disc. Shot? Does that make sense? So if your herniated discs are not the cause of your back pain, shot, no, we don't need another spinal needle.
All right, now. Bye, Mike. Thank you.
If your herniated discs are not the cause of your back pain, then you don't need surgery on them. It's my job and your doctor's job to figure out if your herniated discs are the cause, shot, of your back pain. And the way we do that is we first start by numbing up your facet joint, shot. And we call that procedure a medial branch block. So we're trying to figure out, are your facet joints the cause of your back pain? Or is it the disc? So just so you understand why I'm saying that, 90% of people over the age of 40 have herniated disc in their back. Shot. Very few people actually have pain from those herniated discs. So before you do surgery on a herniated disc, what you want to know is that causing your pain? Shot. And the answer is about 85% of the time, the answer is no, it's not. Incredible. Honestly, I've never had such lateral shot. Such lateral. This is the most lateral facets I've ever seen. Shot. 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 Let's get an AP. His spine is really anterior, and his facet joints are lateral, which makes accessing them incredible. I mean, the angles that I'm looking at right now are phenomenal. Yeah, we're way too lateral. That's a TP. Shot. All right. Lateral, please. So I don't know if you understand the answer to my question, or to your question is this a great surgery for herniated discs? 100% it is. However, I don't know that you need surgery on your discs. Most likely you don't, unless you've already done the medial branch block shot. If you've already done a medial branch block shot, then, and it didn't work, shot, see, that's the facet. Let's go lateral, AP. If you already did the medial branch block and you've ruled out your facet joints as the source of your pain, then yes, the discs then become the number one cause of back pain, the herniated discs. So it's entirely possible that that's what we're dealing with in your case. Shot. Shot. Lateral.
We have another question.
Yes.
We have a viewer saying, I have an L4, L5 disc bulge, right side pain for 2 years, but no numbness in my leg. Why do some people get no numbness, whereas some people do when they have a herniated disc?
Shot. That's a great question. Why do some people get numbness with a herniated disc and others don't? Shot. The answer is that the nerve that's being irritated in your case, shot, that nerve carries information, right? Specific types of information. Number one, it carries information from the brain to the muscle, AP, and it allows your brain to tell your muscle to contract. So it controls your strength, because muscles control strength. Then the second thing it does is it takes information from the skin and brings it up to the brain. The third thing it does is it can go to the joints. So basically it carries information from the skin to the brain to the muscle, or to the joints, and it carries pain information as well as feeling, touch. Let's go lateral. So when you start affecting the nerve with your disc, because the nerves run right behind where the disc herniations are, so a herniated disc in the back of your disc can affect the nerve because the nerves run right behind the disc. So once you start affecting that nerve with the disc, either chemically irritating it or compressing it, you're going to get weaknesses, numbness, tingling, pain. All those sensations are possible. Shot. What determines what happens in your individual case is really individual. Everybody's different. So it has to do with the location of the herniation, I'm sure. It has to do with, you comfortable? All right, we're going to put you to sleep soon. Let's start testing these discs. So when you have nerve that's affected by the herniated disc, you're either going to get weakness, numbness, tingling, or pain, or a combination. And everyone's completely different. Are you comfortable? How bad is that on a scale of 1 to 10? Huh?
10.
All right, so that's where your pain typically is, in that area? All right, so we just did a discogram at 3-4, and the guy had 10 out of 10 pain, concordant. So sorry about that. We're actually testing the discs to see if they're causing your pain. So this goes along with what the question was earlier. I have bulging discs. Would this surgery work? Yes, it will work as long as the pain's coming from your disc. Well, clearly, this patient's pain is definitely coming from L3-4. Now, is it coming from the other discs as well? We're about to find out, unfortunately for him. But we need to do this. It's kind of a necessary step. Let's turn the music off. Are you comfortable now? So you can actually see on that lateral view with the dye in the disc that there's a tear in the back. It's a grade 4 tear. You can see the dye real thick coming back to the back of the vertebral body and the back of the disc. That's a tear. It shouldn't be there. It should be closed up and there should be no dye there at all. That tear is where his back pain's coming from. Sorry about that. Come on, when you hear it and I've injected, you got to take a video or a shot. All right. So that's interesting. How bad was that on a scale of 1 to 10? 10. I don't know why I can't hear the word 10. It's strange. All right. And is that where your back pain typically is? That's a grade 5 tear because you see the dye goes around the herniation in the back of the disc space. So we have 2 discs that we've tested so far that are 10 out of 10. When you wake up, that pain will be gone forever, okay? As long as you don't re-injure your back, you do what I tell you to do, that'll be gone forever. So people are thinking probably, well, if you do this to my back and I don't have a back problem, won't that hurt and cause pain? The answer is no. If you do a discogram on a disc that's not causing pain, typically it will not cause pain during the discogram. That's why this is such a valuable test. How bad is that on a scale of 1 to 10? Huh? 8? Is that where your pain typically is? So L45 is an 8 and concordant. So my suspicions were correct. L23 is painful because he was pointing higher in his back. Look at the dye leaking out around the nerve there at the on the left side. All right. We're going to put you to sleep. When you wake up, everything will be done. So the thing about this patient that's quite interesting is that if you look at his MRI, it doesn't look bad at all. And you really can't see the tears that well, but they're there. They're barely visible. On a scale of 1 to 10, you'd rate his MRI maybe at a 3. And so you'd say, sorry, there's nothing that can be done for you. If you're a normal surgeon that does back surgery on herniated discs, you'd say, well, there's just nothing that needs to be done there surgically. But you know what? These tears don't heal themselves. And that's why this poor patient's been in pain all these years. He's had multiple back surgeries that didn't work for him elsewhere, shot. And we're going to fix him today. All right, so that's going through the lower incision. That's probably L45. It is. So we've taken the needle out. We have a guide wire now. It's going through the incision that we already made with the number 11 blade. And we're going to pass the dilator. It looks like a giant pencil made out of metal or steel. It's German stainless steel. And are you awake? He should be asleep. But he's reflexively responding, shot, to the discomfort of passing this thing through the muscle. And now I'm up against his herniated disc, shot. So what's interesting is if you look at his MRI, you don't see these things because he's not loading during the MRI. Basically, patients lay down, so you can't see any pressure. There's no pressure on the disc. So if they're not standing up or sitting during the MRI, there's no weight or pressure on the disc. You're not going to see some herniations you won't see. Shot. So right now he's asleep. We've put him asleep with propofol. And once we get our needles and into the right place, we always put the patient to sleep. Am I okay to proceed or should I wait? Shot. That's it. So, shot. He's got a big old tear right there. This thing's going in pretty easy. Taking the guide wire out at this point. We're in the disc. We're not all the way in where we need to be, but that's about right there. That should be good. Maybe a little tap more. And now we can't do the surgery through that metal pencil. We got to bring a tubular retractor. So this is a tubular retractor. It's about 7 millimeters wide for the lower back. For the neck, we use a 4 millimeter wide one, so it's even smaller. But you can see right with the camera, Zach, down the hole.
We can see it.
Yeah. So to date, in 13 years of doing this surgery, I've had 0 complications. And I've done about 850, close to 900 of these surgeries now. All of our patients go home. I expect this patient to as well. Now this patient is a little different because he came to us with a spinal cord stimulator that was put in because the other doctors basically just gave up. They're like, we don't know what's wrong with you. We're just going to put this spinal cord stimulator in, which is a battery and wires that go over the spine, and hope that that works, you know, hope it covers up your pain. It doesn't really fix anything, but it covers the pain up. And of course it doesn't work that well. It's really, truly should be used as an absolute last resort when there's no surgery that could fix the problem available. Yeah, you guys know I should be able to talk and not have to tell you the little things that are the same every time. So just start thinking about what do we do the same every time, and let's do it. So I don't think putting a spinal cord stimulator in was the right thing to do. I don't think having two surgeries at Laser Spine Institute before they closed down last month was the right thing to do. This patient has small disc herniations with annular tear. The best surgery in the world is what you're watching right now, the Deuk laser disc repair. How do I know? Because I know all the surgeries that are done in the world. How do I know that? Because literally I'm trained at one of the best training programs in the world, if not the best. And at that time, my attendings or professors did all the surgeries that are done except for endoscopic surgery. And I had to go learn that overseas in Korea and Germany and other places from experts, particularly in the United States for the lower back. But for the neck, it was just the Koreans. Long story short, I know what all the surgeons do out there. And there's a lot of different surgeries that can be done. You can do laminectomies, discectomies, fusions, fusion through the front, fusion through the side, fusion through the back. I mean, the number of possibilities is about 50 different surgeries that could be done. However, the best of all of them is a transforaminal annular debridement with discectomy, and that's what the Deuk laser disc repair is. Are there transforaminal discectomies done? Sure, but they don't do annular debridements. And the annular debridement is unique and only done with the Deuk laser disc repair. We were the first people in the world to publish it. We published it back in 2012. That was 7 years ago. And why did we publish it? Because we were the first in the world to describe. I'm getting a lot of glare. No, I'm just trying to figure out. It's glare off the monitor, probably from this light here. So maybe just turn that light away for a second. Yeah, it's better. So we were literally the first in the world to describe the debridement of the annulus. So far you haven't seen it, at least not in this case. If you've watched many of these surgeries, then you've seen it. But the annular debridement is done with a laser. And you can't do it with any other tool. You could possibly do it with an RF probe, radio frequency probe. But you can see the tear he has right there in the annulus. You see the white fibers of the annulus? There actually is a tear right here, and the blue is the nucleus pulposus stained. So he's responding to this, which tells me this is a painful annulus, which we already know based on the discogram. And I knew based on his exam as well in the office yesterday. So this patient drove down from North Carolina. It's a good 8-hour, 10-hour drive. And he came here because of what we do. We do something that no one else in the world can do, the Deuk laser disc repair. And we do it, it's the least invasive, fastest recovery, and most successful surgery for a herniated disc in the world. That's actually why I do it. Some people may think, well, you do it, because that's all you know how to do. No. Actually, I can do any spine surgery in the world that there is from my training and my experience. And I do fusions all the time, and those of you who have been watching for a long time have probably seen me do a fusion. Is he okay? We do fusions here at the Surgery Center all the time because people's insurance won't cover, some people's insurance won't cover the laser surgery, so they have to have what their insurance will pay for, and that's a fusion, unfortunately. So much more invasive, but a more traditional type surgery, not a newer surgery, laser off. Insurance companies are funny. They want to pay for things that people don't want, and hope that people don't get it done because they don't want it. That way they save lots of money.
We have a question.
Sure.
We have a viewer asking, what will the recovery time be for this type of surgery?
The recovery is a 45-minute recovery, and then they go home. The only thing you can't do is you can't drive that same day. There's also restrictions on bending over. That's really the biggest restriction, bending and lifting. Look at that herniation that just came out from the annular tear. So no bending and no lifting for 6 weeks. When I say no lifting, I mean 25 pounds is okay, but nothing more than that. If you follow those instructions, your back will heal perfect. You'll have no problems. You'll never have another problem with this disc that I fix again. Okay? If you don't follow those instructions, you will potentially re-herniate, have another herniation that has to be fixed. So we do have some patients that are feeling so good afterwards that they think they can climb Mount Everest and jump over the ocean, and they're so excited about having no pain. They're very happy. They forget that they have restrictions. It's very easy to forget. And they do something they shouldn't do. But those things they do are always bending at the waist or lifting more than they should before their disc is healed. So are there permanent restrictions? No. Once you're healed up with your disc, which usually takes a full year to heal, you can do whatever you want and you don't have to worry about it. There's a very small chance you'll get a recurrent herniation. My recurrent herniation rate is 1%. That means in every 100 patients I do, one person's going to re-herniate and need surgery to fix it. Okay? So there's the tear right there. That white stuff is scar tissue. That's where all the inflammation is going on. Once I fix this with the laser, his back pain will go away. Our average relief of back pain is above 92% on average. That's if I took 100 patients that I do this on for herniated disc, their average, if I ask every one of them, how much of your back pain that you had before surgery, how much of that pain is gone? 92% relief is of the pain is what we have as an average. A little bit higher than 92. So imagine being 92% of your chronic back pain being gone with the surgery. That's exactly what the surgery does. What about leg symptoms like pain down the leg, numbness, tingling, weakness? 92%. So it's weird that it's both 92, but it is. And that's the information we get from patients. These are not my numbers. These are the numbers that the medical assistants get when the patients come back after surgery or when we call them to see how they're doing. The average relief is 92%. There's no surgery in the world besides perhaps my open fusions that I do where you get equal results. So what does that tell you? It tells you that the fusion and the laser surgery both really target the same problem because they're really done for basically the same problem, which is pain coming from a disc or pinched nerves or irritated nerves, so pain down the leg. So what that really tells you is that the patient selection is key. If you want to have good surgical results, you have to choose the right patient. And what does that mean? Does that mean you choose the easy patients? No. What it means is you choose patients that have pain coming from a disc, not from the facet joints, right? So if somebody has facet pain and I do a disc surgery like this on them, they're not going to get any better. So that's why you have to make sure as a surgeon and as a patient who's listening to my broadcast that you really understand where your pain's coming from. And that's why I emphasize that so much, because this surgery won't work on somebody with facet pain, or this surgery won't work on a patient with sacroiliac joint pain. Sacroiliac joint pain is really close to the disc, but it's a completely different source of pain. It comes from a joint where your tailbone connects to your hip bones. That's not a disc. So you may have a herniated disc at L5S1 and your pain's coming from the sacroiliac joint, not the disc. If the surgeon operates on that disc doing a fusion or whatever, you're not going to get any better. And that's why there's so many people that have had back surgery around the world that don't get better, because the surgeon didn't operate on the right place, or the surgeon could have, but they have a different place where the pain's coming from now. So fixing back pain is really quite complicated, but it's also quite simple. As long as you, the doctor, and the patient understand the causes of back pain, and there's probably about 12 causes of back pain. When I say that, I mean discs and joints and muscles and things like that. So it's really, you need to make the right diagnosis or diagnoses. And the truth is that about 50% of the patients that come here have pain coming from more than one source. All right? And if you count multiple disc herniations as more than one source, then really 95% of the patients that seek treatment at Deuk Spine Institute here in Florida, 95% of them have 2 sources or more of back pain. And if you don't treat both sources, guess what? Their back pain's not going to go away completely. So for us to achieve a 92.5% relief of back pain with surgery, we have to be making sure that not just are we treating the right source like the disc, but also we're treating all the discs that cause pain. So for example, if you look at this patient's MRI, you might be inclined to say, okay, the pain's coming from L4-5, L3-4, but most people would miss the L2-3 disc. And I tested it today because I had a suspicion it was a source of pain as well, based on where he was pointing, based on the MRI. And we tested it, and sure enough, he had 10 out of 10 pain coming from L2-3 as well. So we're treating L2-3 today as well. My goal is that every single one of my patients go home from Deuk Spine Institute pain-free after their surgery. All right, and they're going to have a little bit of muscle pain. That's normal because we had to pass through the muscle to get to the disc. But aside from that, the pain you had before surgery, my goal is 100% relief. And I'm not happy unless I achieve my goal. And so that's what we expect if you come to Deuk Spine Institute, is we're going to get rid of your pain. And we do it without using spinal cord stimulators and stuff like that. We do put about 20 spinal cord stimulators in, but if you think about it, 20 per year. If you think about it, we have over 30,000 patient visits a year, so 20 is really a small number, right? Most of those people we're able to fix with interventional pain management, which is your rhizotomies from the facet joints, or your SI joint treatments, or stem cell treatments, PRP. We do all of those treatments here. So we're able to fix most people's back pain and neck pain, without actually having to do surgery. Only about 10% of our patients at most get surgery or surgical recommendation. All right, so I'm here zapping away at this herniation. It's actually a pretty significant herniation. All this is scar tissue here. Again, if you look at just at this patient's MRI, you will miss this, because MRIs don't tell you where pain comes from. You have to understand that. What tells a doctor where pain comes from? 3 things. Number 1, the physical exam. You have to look at where the patient's pointing to. You have to do a thorough physical exam. Number 2, your diagnostic imaging. EMGs, MRI, CAT scan, X-ray, whatever's necessary to look at discs and facets and other structures, okay? And number 3, perhaps one of the most underrated but most important tools in figuring out where someone's pain's coming from is something called diagnostic blocks. It's interventional pain management doctors do it. We have a anesthesiologist right now training with Dr. Patel, who's the head of our interventional program. And we have physiatrists we train occupational medicine doctors, anybody that has an interest in curing people's pain from injuries, because all of these problems are result from injuries. And we do training here at Deuk Spine. We usually have 2 fellows a year We actually have an opportunity for a fellow if somebody out there is interested in training. They just need to contact our office. We have opportunities immediately available. We have short fellowships for a month. We have longer fellowships for a year or two. Just depends on what your goals are, what our goals are, and making sure they align well. Diagnostic blocks are a very important tool that we use at Deuk Spine Institute. Probably one of the most important tools that we use. If I had to rate them, I would say the physical exam, the diagnostic block are probably the two most important, even more important than an MRI in determining where someone's pain is coming from. And when I say diagnostic blocks, I would include a discogram as one of those tests. Look at all this blue stuff, herniated disc. The white stuff is scar tissue from inflammation. This patient's had back pain for a long time, I can tell, based on all this inflammation. He's going to be really, really happy when this pain is finally gone out of his life. He's been dealing with this pain for how many years? He's gone all over the country trying to get rid of it. He's had spinal cord stimulator put in that should not have been put in. But you know, when you're a doctor somewhere and you have no other tool to fix someone's pain, all you have is a stimulator, that may be the best option for that situation. So I can't blame the doctor that put the stimulator in. I'm just saying that's not the best treatment. The best treatment is what you're seeing right now, because this patient's pain is coming from his discs, from the tears in his discs, and I'm fixing those tears right now as you're watching. This is the source of his back pain right here. This and the other two discs. Same thing in the other two discs. It'll look identical. All right, we have some more questions there, Zach. What you're watching is a straight firing laser. We use a Homium YAG laser machine to create the laser energy, which is emitted from the end of this glass tube. The red you're seeing is just a targeting beam. And I can tell you this disc is taking a lot of energy. How much energy have we delivered to this disc? So far 30? Yeah, 21,000? All right, so we do have some discs that we've treated at the 30,000 watts. Sorry, joules. So we haven't broke any records. I don't expect to either, because we're almost done. So this is the debridement. What you're seeing is a giant crater where the herniation was and the annular tear was. And now I've gotten rid of most of it with the laser. For those of you who think the laser is a joke, think again. It's actually an extremely important tool. This surgery can't be done without the laser. It's too small of a space. This is a 6 millimeter tunnel. If I put a scalpel in here, the whole space would be filled with a scalpel. You wouldn't see anything. And the scalpel won't do anything either. What we need is we need to remove this pathological tissue that's causing pain, and that's what I'm doing with this laser. Impressive tear. I mean, really a deep, deep tear right through the center of the disc, from the outside to the center. And again, really, really not seen well on the MRI scan at all. Just, that's why this poor patient has probably not had anybody besides Laser Spine Institute take him seriously. And we hear this all the time, by the way. I'm talking about issues that are real during these broadcasts. I don't talk about nonsense. Honestly, I'm the kind of person who doesn't waste my time dealing with nonsense. I'm telling you about real situations in life, real causes of pain, because the whole purpose of this broadcast is to teach people the truth. It's not to sugarcoat or cover up or, you know, basically perpetuate myths and falsehoods about spine care that are all over the world in the industry about lasers or spine surgery or whatever. This is about truth. And so we always show you the whole surgery. We always try to show you the patient afterwards going home, so you could see that how they're doing. If they're local, we'll get them in and we'll do a video a week after surgery, and you'll see how they're doing. If they're international, which most of our patients have become international or out of state over the last couple of months, then you probably won't see them unless we do a video chat. But generally, patients do so well, they want to get on with their lives. I'm the same way. If I have a medical procedure, I don't want to keep coming back to the doctor's office for no reason. So one of the most important things to take away from this surgery is that back pain and neck pain are caused by herniated discs. About 15% of the time, chronic pain is caused by herniated discs. And when you get pain from a herniated disc, it's always from the annular tear. It's always from the annular tear, not the nerve root, not the pinched nerve. When you get pain, axial pain, pain kind of deep center of your spine, it's always from the tear. That's why this part, the debridement, is so important. That's what fixes that pain. Now, if you have leg symptoms, it's either irritation of the nerve by the nucleus pulposus being broken down by your inflammatory process, or it's compression of the nerve. So, I'll ask the audience a question. Taking all patients that have leg symptoms or arm symptoms from a herniated disc, what percentage of those patients have their symptoms in their leg or arm from a herniated disc as a result of pressure on the nerve versus chemical irritation? Okay, versus chemical irritation. The answer is 95% of patients with arm or leg symptoms, it's due to chemical irritation. So there's really nothing compressing the nerve, there's just something irritating the nerve. Very important point. It's important because all these surgeons are looking for a big herniation as the cause of people's symptoms, and they're not going to find it. And that's why they blow people like this patient off. They say, oh, there's nothing surgical here, there's nothing that needs treatment. It's all in your head. Go home and, fine, go home and just sleep it off or rest it off. That doesn't work. And these people don't get the care they need, and they end up being in pain. Go ahead, guys, switch it whenever you're ready. I'm prepared. All right, thank you. Nice job, by the way. So you see, if it's done properly, you just get a little blast of bubbles, and you don't have any other issues.
We have a question.
A question? Of course. I thought my audience knew everything by now.
We have a viewer asking, does the laser also cauterize the tissue while you are using it in the surgery? And if so, is that why you prefer using the laser for these kind of surgeries?
Is that why what? I didn't miss the last part.
Is that why you prefer using the laser for these kind of surgeries?
All right, so we have a very astute observer who's asking questions about the laser. The first question was, does the laser cauterize blood vessels or tissue? So they asked about tissue. The answer is yes, it cauterizes tissue with the heat that's generated at the tip. So if you have a bleeding blood vessel, it'll cauterize it most of the time. Then the other question was, is that why you use the laser? The answer is partially yes. So I use the laser for several reasons. Number one, that blue tube you're seeing is 0.5 millimeter, 0.5 millimeters. So it's very skinny. So I can actually see what I'm doing with the laser taking up the vast majority, very little of the tubular retractor. Does that make sense? So in other words, one of the advantages of the laser is that you can actually see what you're doing because it's so skinny. Another is that look how nicely it gets rid of this tissue, this bad tissue, the stuff that's causing the pain. It literally just blasts it into little chunks, right? And it really doesn't obscure your view very much at all. You can actually keep working and blasting at the same time, right? So think about those people that mine minerals out of mines, you know, these open mines, right? What do they got to do? They lay the dynamite, then they run away and they stop working for a while, and they blast it and they wait hours, if not a day or two. So if every blast I did, I had to wait, imagine how long the surgery would take. So the fact that the laser blasts the tissue away, and you can keep working while it's doing that, and start looking at the next place you're going to blast, so you don't have to stop working, basically. So it's a wonderful tool for that reason. Also, not only does the laser deliver a burst of high energy, which breaks up the tissue into little bits and pieces that then float out, but also the laser creates a pulse, a shock wave, basically, in the water. So this is all filled with fluid in here, saline, and the laser literally creates a double shock wave that blasts the tissue. So once it coagulates it or cauterizes it, it then blasts it out of there. So it's no longer there. So I can move on to the next piece of tissue that's still attached. So basically any loose pieces, it actually helps move them out of the way. So it's kind of like an excavator coming in after you dynamite a whole side of a mine wall. You dynamite it, then you have all this rubble that sits there and blocks your access. You got to take the rubble away. That's what an excavator and a dump truck do. So this is like all those tools together. So it blasts the tissue, it moves it out of the way, and then the irrigation transports it out of the tube. So it's really nice. You can keep working. It's very efficient. So we call that efficiency, right? So the laser is a very efficient tool, and it also cauterizes blood vessels so they don't bleed. There's no better tool in the world for this application than the laser. I'm telling you, there's no surgical instrument that works better. That's why I use the laser. It's expensive. They run about $120,000 each. You have to pay the technician. You have to pay for the upgrade, upkeep and maintenance of the laser, calibration of the laser. You have to, every time we bring the laser to the facility, we have biomedical engineering sign off on it. That costs money. So they're very expensive tool. It's by far the most expensive tool we have, yet it's worth every penny we pay for it, because this surgery is not possible without it, and I can't get this patient's pain relief without it, right? So just to give you an idea of how valuable the laser is, we charge a certain rate for the surgery. Okay, if the laser doesn't show up, I still charge the same rate. All right. So why would I waste money on a laser or a tool that wasn't necessary? Think about that. It's because it's 100% necessary. If you notice, 95% of the surgery is the laser. Maybe 5% is the traditional surgical tool, pituitary rongeur. So anyone who tells you lasers aren't necessary or useful is lying to you. It's just because they don't know how to use it. That's what I always find out. I laugh at it because patients will come in and say, yeah, I talked to my neurosurgeon and they said that lasers don't do anything and they're useless. Well, what's useless is probably your neurosurgeon. Carl liked that one. All right. Well, there's a lot of calcification of ligament here, bone spur, but we are pretty much done at this level. The nerve root is right up there to the 9 o'clock, and I'm pretty happy with that. Laser off. Gonna turn on the suction, shut off the irrigation. But we're done with that level. We're gonna suck the fluid out. You'll see a little bit of bleeding. That's normal. Fluids out. Scope off. So that's one of the 3 levels done. We're going to get the tube out and start over at the next level. Let's get the scope in. Watch it here, Luis. Come on. Put that down. We need the scope in, please. What is it? Yep. So we finished one disc. Luis is holding pressure on the patient's paraspinous muscles so they don't bleed. I know where the guide wire is. I'm going to grab it myself. Okay. All right, whenever you're ready. So does your fluoro go further to the ground or not? I'm sorry? All right. Did the table go down? That's what I'm trying to figure out. So be aware of what's up here and that you're going to deal with when I'm done, right? You got a needle and you got this needle to deal with and you got that needle that I just took out. Are you guys set? All right. Did you lower the fluoro? All right. So next disc is going to be 3-4. You can see the guide wire in there coming out of the tip of the needle. It's skinnier. We're going to take the spinal needle out. Shot. So for those of you who like watching these videos and appreciate what Deuk Spine Institute has done for the field of spine care and spine surgery, we are creating an app, our first ever app, and thanks to the work of Zach and Sonny, and that app is almost ready to be launched. So you'll be able to download it on your phone, whether you have an Apple or you have an Android-based phone. Shot. You'll be able to download the app, and what our app is going to allow you to do is, number one, have access to our educational content. Also be able to watch live surgeries. You'll be able to interact with our patient services, request appointments. Eventually you'll be able to also schedule a short video conference with a doctor, or a long one if you want, and be able to do like a video chat with one of our doctors on your phone at your scheduled appointment. What else, Zach? Eventually billing and payment.
It can upload MRI images from the phone as well.
Upload MRI from your phone, right? So we could do a free MRI review.
It's got an interactive symptom checker.
Interactive symptom checker. Shot. Why am I repeating you? You say it so well. Zach used to be so timid and shy when he first came to Deuk Spine. Right, Zach? He's not going to answer, are you?
I suppose so.
We're bringing you out of your shell. Shot. Zach and Sonny have done a phenomenal job on our IT and our web, and done a lot of work for the foundation, like right now, broadcasting a live stream so you all can learn. All right, that's our latest shot. All right. So it's good that we can see the sacrum at some point, so we can look back and say we know where we were. So you want to probably show us the sacrum a little bit just to make sure. All right, so sacrum 5, 4, 3. We're at 3, 4. Everybody agree? All right. It's one of our discs that we're treating. So the tubular retractor goes now over the dilator. We're going to run the tubular retractor shot over the dilator and into the disc space. I want to keep an eye on shot. The dilator, I want to make sure it doesn't come back or go forward. Shot. Shot. So now it's advancing, as you can see. So I just have to be more cautious. Usually it's because there's some tissue trapped. Shot. Shot. It's like a little turtle head sticking out. Alright, so now the tubular retractor is inside the disc space. I can take the dilator out. Shot. And there it is. Fluoro will go out at this point, and we're ready to do the next disc. So this is the next herniated disc that we know is causing pain because we tested it intraoperatively with a discogram at the very beginning. If you want to rewind, you can go back and see that. But this patient had 10 out of 10 pain here. There's the blue dye that we injected earlier into the disc to test. Why am I so fuzzy? We need to wipe the tip. It's probably got some schmutz on it. And down. We're still fuzzy and cloudy. Carl, what are your thoughts? Maybe it's where the camera attaches. Hold on. Let's clean this. It's not the light. It may be water here where the camera and the scope meet. Is that better? Let's see. So the camera looks good. It's better. I think maybe the well, it could be a little bit overexposed, but it could also be that we need to send it back to Germany and spend another $5,000. We're gonna have to raise the price of these surgeries. Wolf has gotten ridiculous with the pricing of repairing these scopes. Alrighty. Where is my pedal? Why is it so wet here? I feel like I'm about to get in the swimming pool. We need a towel. I think we're overexposed. Let's turn the brightness down. That's better. Maybe one more click. That's good. Thank you. All right. So again, we're going to get into this. There's a tear right there that's scarred up. Yeah, there's something going on with the scope. Carl. Freaking scopes, man. Huh? Yeah, but what I'm saying is it's still got a haze to it. Kind of a haziness. You guys see it, right? Or is it my eyes? It was fine at the beginning of the case. Unreal. Huh. That helps for sure. That's a lot better actually, Carl. Yeah. How did that light get moved again? I guess we just brought it in. All right. You're a magician, Carl. I love it. Thank you. Any questions from the audience, Zach?
We do have one.
Stand by.
We have a viewer asking, are there any professions that are more likely to cause back problems that you have seen?
Are there any professions that are more likely to cause back problems? I think, I hate to say it, but golf is one of them. just because of all the massive forces that people put on their backs when they're twisting, to hit the ball. So driving in golf, like wrestling, gymnastics, those are all professions. You got to understand something, that getting a herniated disc that causes pain is actually, you're right, it has to do with your profession, but it also has a lot to do with your genetics. Like, just you have the genes of a disc that's likely to cause pain. Because back pain from herniated disc, 100% in my opinion, runs in families. There's a genetic component to it, or a familial, we call it familial component, whether it's learned or nature versus nurture. If that's what familial means, it's both the nature and the nurture. How much one versus the other. I personally think there's a strong genetic contribution to something to do with the, biochemical or cellular properties or physiological properties of the disc and the inflammatory system in that person. I don't know which it is. I don't have an answer for you. But I just know that there are people that are more prone to having disc injuries that cause pain. Now, everybody gets disc injuries, right? Even I have disc injuries, but I don't have any pain from it. And I haven't had it treated. But the fact of the matter is, I can tell you at least 90% of people over the age of 40, and more likely 100, have disc injuries. But very few have pain or symptoms in their back or leg. So why is that? Why is it that some people do? And those people that do have symptoms typically run in families. So there's going to be a person with a back problem from a herniated disc, and it turns out, I can't roll it. It turns out their brother or sister also have a problem, mom and dad, or mom or dad usually. So I truly believe that there's a genetic component that you're born with that somehow affects whether your disc herniations are going to be symptomatic. So again, not so much the fact that you're going to get a disc herniation, because everybody seems to get them, but really that it's going to be symptomatic and need surgery. One thing that I've noticed in my career of operating on spines is that the people that I take to fusion surgery, and I'm sure these patients would also qualify that get laser surgery, is that I've noticed there's a problem with the posterior elements. So usually it's a short pedicle or a hypoplastic pedicle in the back, usually at L4 or L5 or S1. So there is a structural anomaly that exists in patients that end up having surgery with their posterior elements. That they are born with, not that they acquire. You see, a disc injury is something you acquire in your lifetime. You're not born with a herniated disc, but you are born with short pedicles. You are born with hypoplastic pedicles. So look at that tear, is just amazing. I'm going to show you this tear. Look at the tear right there in the annulus. You gotta move your hand. Move it towards me. There, yeah. Okay, so if you bring your hand down here, you're holding the wire, right? I'm trying to twist it. No, I'm just telling you are, but you're holding the wire. Right. So if you do this, am I going to be able to twist it? Or if you take it to the extremes, I can't, right? So you gotta, if I'm not able to roll this thing and get in position where I need to be, you gotta move your hand. So bring your hand to me. I know it's hard, Luis. I know it's not easy. But anyway, that was the tear right there, and now I'm debriding the tear.
We have another question.
Yes.
We have a viewer asking, is there anything done to maintain the disc space following this procedure?
Is there anything done to maintain the disc space following this procedure? So, yes. What is done? What is done is what is not done. What we have not done is take out the whole disc, have we? All we're taking out is a small part of the disc. So there's actually no additional loss of disc height as a result of this procedure. We're only taking out 5%. And that 5% we're taking out is pretty much already out. So it wasn't in the disc to begin with. It's been out of the disc when the patient showed up. A herniated disc means the jelly in the center of the disc is squeezing out through a tear. We're taking away the jelly that already squeezed out through the tear, and we're taking away the tear. So we're really not taking away any normal disc, and we're leaving the rest of the disc alone. And that's why this procedure, one of the beautiful parts of the Deuk laser disc repair is that we're not actually removing any normal disc. We're only removing pathological disc that's causing problems, symptoms. So because we're not taking away any of the structural disc that's there to support the weight of the body and the segment, we're not going to lose any height as a result of the surgery. Now, did the patient lose height to begin with? Yes. When they injured their disc, their disc space collapsed, but we're not collapsing it more from the surgery. We're only removing the annular tear and the herniated disc, which is blue, by the way, just so you know. That's the blue stuff we're grabbing. It's a special dye we use that actually stains degenerated disc. So you see, I tried unsuccessfully to use the grabber several times. And that just highlights and illustrates why traditional surgical tools don't work. That was a pituitary rongeur. It's used by pretty much every neurosurgeon that I know in the world, and yet it's totally ineffective, except to grab out chunks that are already freed up. So you need the laser really to free up pieces. That's what the laser does better than anything else in the world. So don't believe people who say laser is ineffective, unnecessary. It's really an amazing tool. And honestly, I wasn't really trained heavily on it as a resident in neurosurgery. We did use it for a few different applications, like in kids that had obstructive hydrocephalus, where the fluid in their brain was blocked from leaving the brain and it would build up and cause their head to swell. We would do a endoscopic third ventriculostomy with a laser. And then I used it also in pediatric patients that had that we had to do a dorsal rhizotomy procedure. So changing irrigation again? Go ahead.
We have another question.
Sure.
We're asking, can a medical spine support brace help to prevent and treat lower back pain?
Can a medical spine support brace help prevent and treat back pain? No. Absolutely not. Bad idea. We don't really recommend bracing at all to treat back pain. What bracing does is it causes your muscles to atrophy and get weaker. So there's really no reason to use a back brace. It's completely unnatural. We use back braces for our patients post-operatively. So I give every one of my patients a back brace after this surgery. And the reason is I don't want them bending over, picking something up and re-injuring their disc. So the back brace is really just to prevent them from doing something they're not supposed to do. But as far as a treatment to cure back pain, no, it's a bad idea. It doesn't work. It only makes your muscles atrophy and get skinnier and weaker. And that's bad for your posture, bad for your gait and station. So we do not recommend back braces to treat pain. We recommend back braces after spine surgery to prevent patients from re-injuring their back for about 6 weeks. And then the brace comes off and we're done. We also recommend back braces for fractures. If somebody has an osteoporotic compression fracture or a traumatic fracture, sometimes you can put the patient in a back brace for 6 weeks to 2 months and they'll heal. So we do use back braces to treat osteoporotic fractures. We use back braces to treat post-operative patients who have had back surgery and they're healing and they need to just restrict their movement. So we put them in a back brace. But aside from that, we never use a back brace as a primary form of treatment for any any back problem at all. It's a big mistake.
We have another question.
Yeah.
We were asking, do you think that diet shown to reverse cardiovascular disease could also help in starving off annular disc degenerative processes?
All right, I'll have to have you repeat the question. I didn't hear it.
We were asking, do you think diet shown to reverse cardiovascular disease could also help in starving off annular disc degenerative processes?
So do I believe that diet or cardiovascular health can prevent degenerative disc disease?
They said, do you think that diet shown to reverse cardiovascular disease could also help in starving off annular?
What is it, diet sure? I don't think diet or any kind of treatment of cardiovascular disease is going to help you with your discs. No. I don't know that I heard the question entirely. It's pretty loud in here, so I apologize. We have a lot of machines making a lot of noise, and it's hard for me to hear every word that's said, but... Diet?
Yeah, diet shown to reverse cardiovascular disease also help.
Oh. Do I think that a diet that has been shown to reverse cardiovascular disease will fix a disc tear or prevent a disc tear? 100% no. I don't believe that cardiovascular diet or any of those things are going to fix your annular tear and herniated disc. Not even close. Nope, this is a real phenomenon, and this is a real problem, and it's not going to be fixed by diet. It's not a problem of fat people. You know, everybody thinks that back pain and herniated disc is a problem for fat people. It's 100% wrong. We have so many skinny people that have back pain and herniated discs, and they get better with surgery. Even, you know, it has nothing to do with weight. It's misinformation. That being said, I think being a healthy weight, an ideal weight, is good, but it's not going to fix this problem. Look at that tear. That's just amazing. It's been there a long time. You can tell this is not something new. This patient's herniated disc has been there a long time. And it's so sad to me that a human being would suffer for so long unnecessarily because their doctors fail to make the right diagnosis or fail to provide the right treatment to the patient. And yet, I see it over and over and over again all around the world from people everywhere. It's really a shame. It's just a lack of understanding of the disease. A complete lack of understanding. And 100% of spine surgeons will tell you they know everything, they know what they're doing. And yet, truly, they probably only know about 50% of what they're doing. But they would never accept the truth mentally, psychologically. They don't want to live with it. It's called denial. Even doctors have denial, you know? Denial is not something that our doctors are immune to. I think we're done at this level. I mean, we've reached the end of the tear. There's the epidural fat. The nerve root will be up here on the left side. It's actually got some fat there. So, yeah, I feel pretty good. That looks good to me. Let's get the liquid out. Scope off. One more disc to go and we're done. Then we'll have to take the stimulator out. Huh?
He has percutaneous.
Yeah. Should be easy to get out. Alrighty then. So, you hold pressure.
Yes, sir.
We've got one more needle. I need someone to pull my skirt up a little bit. Who wants to volunteer? Lori. So, I just need you to grab the edges. You see? And just literally twist and wiggle, and it's about to fall off. A little bit more. A little bit more. Yeah, you're good. Keep going. That's perfect. Thank you. If only I had a bigger butt, I could hold that skirt up. Yes, you have a question there, Zach?
We do. We have a viewer asking, can this laser surgery help treat bone spurs?
Can the laser surgery help treat bone spurs? The answer is yes, as long as they're small bone spurs, small bone spurs. So not giant bone spurs. Big bone spurs, no. All right, we need fluoro. Where's fluoro?
Lori, can you check what's going on with the monitor, please?
What you guys should really be asking is, why am I wearing a skirt? Is that our picture? So why do we lose the fluoro? All right. Let's try to figure it out. So this is going to be the 2-3 disc. So we ended up doing L2, 3, 3, 4, 4, 5. All right. And they were all painful. No signal. All right. So I'm going to take this out. I need fluoro to stay with me. Sorry, folks. You guys won't be able to see fluoro, but I can. And we'll get the fluoro back up and running as soon as possible so you can see. So in the meantime, just enjoy the eye in the sky view, third person view. I haven't cut it yet. Let's wipe it here. All right, so you can see the other incision. Now we have to make this one a little bit higher up.
We have a question.
Did Carl do it? Did Carl make it happen? So Carl, when you're on your sailboat, shot, can we email you or can we satellite phone you? Huh? You told me you're having a satellite phone. How can you have email but not a satellite phone? I don't get it. How do you get email way out there in the middle of the ocean? Is that a satellite email? SSP? SSB? Shot? Ham radio. So you can send emails. Over the ham radio? Shot? Huh? Packer modem. Carl has been preparing for doomsday now for quite a while. If you couldn't tell. He's ready. He's ready for the zombie invasion. He's like, I'm out of here. I'm getting on a boat. Zombies can't sail. Right? Shot? Zombies cannot sail boats. They can't get me. Shot? Huh? You what? You drive down 95 with him? So we'll take the question now that we've talked about Carl's antisocial behavior. Here. His fear of zombie invasion.
We have a viewer asking, what is your opinion on having chiropractic manipulations after this procedure?
What is my opinion on having chiropractic manipulation after this procedure? Is that our x-ray right there? So sorry we lost the x-ray feed again. What's going on, guys? A loose wire or what? Sounds like we need our IT guy here. So, what is my opinion on chiropractic manipulation after this surgery? I am a very big believer in physiotherapy, including chiropractic and medical massage and physical therapy. All of these patients, every one of them, for their neck and back, doesn't matter, is going to have chiropractic care after surgery. Generally, it starts 1 week later. Shot? We don't want to start it too soon, so we give them about a week to recover, and then we start physiotherapy. Is chiropractic part of that program? 100% yes. It's not all of it, though. We do other things, other modalities, like PT and whatnot as well. All right? And medical massage. That's us? Great question. So yes, I'm a big believer in chiropractic, especially after these surgeries. The truth is that we have a pretty specific program. Damn, shot. The program involves, like I said, PT, medical massage, and chiro. Shot. There we go. But the specifics of the program, I did not design them. Dr. Schrumpf did, and she's the head of our therapy. And I don't know, like, when people start doing what different things, you know. But definitely we use chiro, and we use PT, and we use medical massage for everybody. As a matter of fact, that's one of the problems with patients who don't stay long enough to get that treatment, is that sometimes they're going to end up with, you know, having a longer healing period than those people who can stay and get the right exercises to do.
We have another question.
I'll take that question.
We have a viewer who says, I'm 22, I'm not having lower back pain, but an MRI I got 6 months ago showed I have a bulging disc in my lower back. Is there anything I should do about that?
All right, so we have a young person who has a bulging disc on an MRI. Is there anything they should do about it? Well, so the fact you've got a bulging disc tells me you've had an injury to the disc, right? Because you weren't born that way. So somehow you've caused an injury to the disc. Specifically, you've torn the annulus, and now the nucleus is coming out. Is there anything you should do? Yeah, if it was my back and it's not hurting, I want you to have a normal life. But at the same time, if you can avoid any kind of heavy repetitive lifting and twisting. So repetitive lifting and twisting. In other words, you don't want to go work for UPS, okay? But aside from that, aside from trying to avoid jobs or activities that are repetitive lifting and twisting, there's really not much else you can do. There's no medicines that fix annular tears. You know, it's just your body wants to fix it. It'll do its best job by using inflammation, and hopefully it'll be limited and it won't be very much, and it'll get the job done quickly so you don't have a lot of inflammation. Long story short, there's nothing you really need to do. Definitely you don't want surgery. You don't want to do surgery for a herniated disc that doesn't cause any pain or symptoms. You leave those alone. You don't really need physiotherapy. You don't really need chiro. You don't really need anything except just be careful and just, you know, understand you have an injury to your spine, and it'll always be there, and you just don't want to make it worse. So try to protect your disc. That doesn't mean don't exercise or work out. I think it's good to get in the gym and work out and strengthen your back. Try to get a personal trainer involved. Tell them that you have a disc injury and that you want to strengthen your back, your muscles. And there's certain exercises that you can do to strengthen your lower back and your core muscles, and that's good. You want to strengthen your core muscles. But you don't want to do like clean and jerks or deadlifts or really even squats, because those put a lot of weight on your lower back. You're going to end up hurting your disc. So no deadlifts, no clean and jerk. You know, military presses, keep it light, high reps, lots of sets, but avoid heavy weight on your lower back. That's the best advice I can give you. Hopefully that's what you were looking for. But you definitely don't need surgery. Don't let anyone operate on that at this time if you're not having symptoms. So this is our last disc, and that we're fixing, and we're right inside the annular tear. This is L23. Once again, this entire white wall here is just scar tissue from chronic inflammation at the annular tear. Totally abnormal, shouldn't be there, but in this patient it's there. And again, if you look at this patient's MRI, the most surprising thing is it looks almost normal. And I can guarantee you, that's why one of the reasons the patient ended up here was that their own spine doctors probably said, hey, your spine looks fine, there's nothing wrong with you, just go live your life. The problem is these people are in so much pain they can't live life, and they're not being their issue isn't being addressed properly by their doctor. And I hear this all the time. People are just like told, oh, there's really nothing wrong, just learn to live with it, it's just arthritis, it's just a herniation, it's just pain. But you know what? People can't live with it, it's too painful. And that's why we're here at Deuk Spine Institute to help those people out. I don't believe people should live in pain and suffering. I think they should get the problem fixed. That's my opinion. For those people who want to get fixed and want to move on with life and have no back pain, you want to come to Deuk Spine. That's what we specialize in. You can see the fibers there. So you can see right there, those fibers, they're running up and down. I mean, you can't really tell, but at 12 o'clock is the midline. And those are the posterior longitudinal ligament fibers. We're not really interested in getting through them or invading them. They're not part of the problem. This right here is all herniated disc. Right here, all the blue stuff right up against them. And that's what I'm trying to get rid of. And then, of course, annular tear laterally. Yes?
We have a viewer asking, is...
10 minutes? Oh, actually, we have to do the stimulator. Sorry, go ahead. I'm listening.
Is it still possible to have this laser surgery after having multiple previous spine surgeries?
So is it still possible to have the Deuk laser disc repair surgery you're watching now after having multiple previous spine surgeries? The answer is yes. The only issue you're going to have is if your previous spine surgeries were fusion or artificial discs, then I cannot do this usually at the level you've had your prior surgery. However, if you're having pain in your back, then you're most likely having pain coming from the next disc, above or below the fusion or artificial disc. So yeah, this surgery would definitely work for that. And we've done that many times, by the way. For whoever asked the question, the viewer, we've operated on many people with multiple prior back surgeries or neck surgeries. It's not a problem. And they do really well. So I'm going to finish up this last herniation, and then this patient has a unique issue. They have a spinal cord stimulator that was put in by some other doctor to try to cover up their back pain. It didn't work. That's why they're here having real surgery. And we're going to get that spinal cord stimulator out, so you're going to get to watch it, okay? So if you've never seen a removal of a spinal cord stimulator, you're going to get to see it. If you've never even seen a spinal cord stimulator, you're going to get to see it. Okay? Spinal cord stimulator is our battery generator. We call it a generator because it's more than just a battery. It actually has a computer built in that controls the electricity distribution of the battery to the lead. You're going to get to see 2 round leads, I think, right? 2 perk round leads. So you get to see what a spinal cord stimulator looks like. Should be the last part of the tear. Right there, you see the inflammation, the red stuff. There's some calcification there. It's turning golden color. Those are some of the smaller bone spurs we were talking about. All this is scar tissue, this white stuff. So thick. Look how the laser really doesn't do much to it at all. It takes a lot of laser energy to remove this stuff. But we have to, because this is part of the annular tear. If we want the annulus to heal, we got to get rid of this stuff. And by the way, there's little islands of granulation tissue embedded in there that are causing this patient's back pain. Standby laser. Let's see if we can't grab some of this out. How's our patient doing? Good. Stable? Fantastic. Yeah, it just doesn't come out. Yeah, it's not going to work. Laser. The laser really is the best tool. Those of you who watched a few of these surgeries understand that. I was the same way when I got done with residency, you know. Where I went to residency at UF in Gainesville, the whole attendings and all the residents used to make fun of Laser Spine Institute, and they would just kind of laugh at them and their use of laser and spine. But when I got out, I had the ability and opportunity to go and learn and see what they did, and learned from a few other endoscopic spine surgeons, like I said, overseas, Germany, Korea, even the United States. And when I saw the results of the surgery and how small the incision was and how quick the patients got out of bed and were back to normal life, I thought, wow, this is impressive. So of course I wanted to learn it, because I always want to provide my patients with the best that's available in the world. So I learned the techniques and modified them and made them better. And now I have truly at Deuk Spine Institute the best results in the world with endoscopic surgery. There's no one else that has a 0% complication rate. In 13 years, by the way. 13 years of doing these surgeries, 0 complications. There's no other surgeon that's ever had that. And the success rate is getting rid of 92% of pain on average is also the highest out there.
Just gonna switch to irrigation again.
Now we're going through a lot of irrigation, huh? How are we doing on irrigation, by the way? Is that still in short supply? You know, these companies, they make up these fake shortages so they can charge us more money, and the hospitals more money, for supplies. It's incredible. That's what Congress is dealing with right now with the pharmaceutical companies, huh? Thrombin? So because we're not using all the thrombin things, huh? Lidocaine, Marcaine, thrombin. Wasn't that thrombin rep here? Like, we talked to the thrombin rep, right? Did they want us to use some other product of hers? That we said no? Huh?
Yes,
She did, right?
a month ago.
Right? She's something else she was peddling. And we said no, and then I think she's like, well, we're running out of thrombin. That's how it is, guys. You think it's a joke? It's no joke. It's greed. Corruption. Right here in the good old US of A. Corruption at its finest.
We have a,
Enron style. Fake shortages of resources to jack the price up, bolster profits, yet deprive people of medically necessary care, because the facilities can't have access to what they need to help people get better, healthy. It's crazy. Yes.
we were asking, in the surgery, are you slowly pulling the tubular back out through the tear while simultaneously breaking apart the herniated tissue with the laser?
So somebody's asking during the surgery, am I pulling the tube out of the disc? The answer is yes. And as I do that, I'm exposing more of the annular tear at the top so I can zap it away. So yeah, that's exactly what's happening. Just about done here. So I'm going to pull it back until I see the epidural space, and that's where the annulus ends. I'm starting to see a little bit right up here. Again, taking a lot longer than normal because there's so much scar tissue. All this stuff here is bone spur and scar tissue right there, right over here. If this was just a fresh herniation, like within 6 months of it happening, then this would be so much easier to deal with. We would be done with the case. We would already be packed up, ready to go home. Fact is, that all this scar tissue takes so much laser energy to get rid of. But we're just about finished. And then we're gonna get that stimulator out. So I feel pretty good. I know that the discs that we had treated were definitely causing this patient's pain. We know that because we did a discogram called an evocative discogram, and definitely showed pain coming from those 3 discs. This is lateral here in the foramen. It's kind of a bulge here and a lot of scar tissue. I don't want to leave this because it might pinch the nerve afterwards, because the nerve is right behind that metal wall. So once I take the metal tube out, the nerve will be interacting with this lump, and now I zapped it down. That was lateral in the foramen. This is medial. A lot of scar tissue, as I said. Just about done. So if I had to guess, I would say this patient's herniation here has probably been here for at least 5 years, maybe even 10. This has been going on for a long time. All right. We're done. So laser can get out of here if you guys want to go. Standby laser. Let me just take one quick look. That's the epidural fat. Herniation's gone. I think we're good. You guys can get out of here. All right, so we're just gonna suck all the juice out. Scope off. No, thank you though. You're gonna put it in the report, right? Yeah, that's good, thank you. All right, so tubes out. And I don't need that fluoro. Nope. Thanks, just keep it sterile and keep it over there. You're gonna need to move it away further, okay? So Luis can get in here and help me. Drop the table all the way. No. All right, so where is this battery? Right here? Skin knife? Thanks. Let's get local first. Where's local? Is there epi? So the first thing we're going to do is numb up the skin so we can get the generator out. And not only are we numbing the skin here, folks, we're actually injecting epinephrine, a little bit of epinephrine. And the reason for that is epinephrine causes blood vessels to close off. So we want to close the blood vessels off here where we're going to cut. Anybody know why? We want to stop the bleeding or minimize the bleeding, right? So by minimizing the bleeding, it's better for the patient.
We have a question.
Sure.
We have a viewer
Yes,
asking, how large was the incision and the tube for the laser part of the surgery?
How large was the incision for the laser? All right, take a look right here. You guys see him? Zach?
Yeah, we see it.
So look at my finger. Look how tiny those incisions are. They're 7 millimeters each. All right. Yep. Come on. Let's move it along. I like efficiency. So now we're going after the generator. You can see how much bigger the incision is. You don't want to use a sharp knife when you get down to the generator. You only want to use a sharp knife under the skin. On the skin. But you don't want to use it under because you can actually cut the lead accidentally. Huh? Trust me, I'm going to try. Coker? Can you guys see this thing in here? What's your face? See this? Everybody see this? Come on. Let's have a yes. All right. This is your generator battery, right? So it stores electricity to run the generator for a few years. Plus it has programming that you can do through the skin. Got it?
Are you gonna put the lead all the way down here?
Hmm?
All the lead comes?
I'm going to try.
Right. Nice.
I think it's anchored. Hold this over. Hold this over. Get a tool. Hold it over. I didn't ask you to do that. Give me a pickup, please. I asked you to hold the skin over. There you go. Watch your finger. Move that here. Move that here. Why would you want to bring it close to the skin edge? Let me have it, please. Yeah, maybe looped. So, skin knife. Skin knife. Now, we just made, where's the actual old incision?
That's it.
So it's,
the old incision, yeah.
alright. It's unfortunate that he burned himself. Take this. Retractor. Need light. So when people put these things in, they usually anchor you. They usually anchor the leads down. These must be light. So there it is. The anchor. How's he doing? Nope.
No.
Do not cut them. Yeah, but I don't want to. Let me have a coker. I don't want to take away something that I might need until I know for sure I don't need it. How's he doing? Yeah, that's why. I don't know. Maybe. How many perk wires were there?
Two.
There's one there.
There's another one.
I see. No, there's some weird. Don't pull too hard. That's why we were never going to get that out. It's from below only. Look at that thing. This is Boston Scientific. Coker, please.
Perfect. Okay.
Let me have these. So we got the leads off the patient's spinal cord. Let's have a scissor. So this wire should come out easily. This one should come out easily too. There they are. There you have it, folks. $35,000 piece of equipment, and the two leads that were in the spinal cord can see the metal contact points. Shouldn't have been put in the first place. All it took was some laser surgery at Deuk Spine Institute. We could have fixed this patient's back. All right, let's have irrigation. Just a waste of money, honestly, a waste of resources, and more importantly, the patient suffered all this time. Suck, please. Suck, suck, suck. Patient suffered all this time unnecessarily with pain from a treatment that doesn't really work when there's such a better treatment available. The Deuk laser disc repair. Huh? So this is betadine, kills any bacteria that might be in there. We don't expect any bacteria to be in there, but it's always good to take a precaution. There's a pocket there, it's full of scar tissue. Good job. Nah, I'm good. Alrighty. See how much fun spine surgery can be? You have an Army, Navy or something? That's alright. I don't know. This guy's not allergic to vancomycin, right? Alright, good. That's good. Put a little vancomycin in here. Alright, let me have a suture. Let's pop off. Just the way I like it. Alright, we're going to go ahead and close the incision. I haven't closed an incision in a long time. I actually have people that close incisions for me. But it's kind of like riding a bicycle. As a surgeon, you never forget how to sew. Everything okay, Lori? So spinal cord stimulator has been removed completely. We don't have any clinic today, right? So the purpose of the crosshatches is to make sure when we bring the two edges of the skin together that we put the needle in the right spot so that it actually brings the skin edges together properly. See? If you mark the skin before you cut it, you know where every single cell is supposed to come back together. That way you can have a visual representation while you're closing. 3 more sutures? Really? Thank you. Watch the needle. I don't want it going through the drape. I think we'll be all right. We should have, what, 2 more after this or 1 more? That's plenty. Sorry if I'm blocking your view, folks. What other questions do you all have? Just as every patient's needs are different, every surgery we do is slightly different. In this patient, they needed a spinal cord stimulator taken out. It wasn't doing any good for them. As well as they needed 3 discs fixed. We didn't know that for sure going into the surgery they needed 3, but the discogram definitely confirmed it. Because there were 3 discs causing his pain. 2 at 10 out of 10 and 1 at 8 out of 10. We're done. You can save that suture. Scissor. Huh? Yep. You guys know how to do the staples here? It's a rhetorical question, but you gave me a good answer. So look, Luis, if you cut the suture at an angle, you see how it's an angle to the incision? You always want it to be perpendicular. You want to put your scissor on the suture and bring it down to the knot inside and cut it. Do you see the tail sticking out? You don't see any tail sticking out, and that's because of this technique. If you do it wrong and you cut it like this over here, there'll be a giant tail sticking out. It's so simple, and yet so many surgeons do it wrong.
Thank you very much.
No, thank you guys. Don't forget these two.
Yes, sir.
Good job.
Thank you, sir. Thank you.
Carl? Huh? No. Post-op x-ray, probably a good idea to show there's no stimulator left. I've got one of your Ratex off the field. It's going in the garbage. Nice work, Dr. Santiago. Nice work, everyone. My nurses. Everyone did a great job. Amy, great job. So for those of you watching, I'll come to the conference room, mission control with Zach, and I'll answer a few more questions for you. So get them ready. Start typing. Okay, folks, Dr. Deuk Majan here, Dr. Ara Deuk Majan, CEO, founder of Deuk Spine Institute, Surgery Center of Viera, here in Melbourne, Florida. For those of you who wonder, who am I? Who is this guy that talks to us from the operating room or microphone? Just to give you a little bit of background, I was born in Germany to a military father in the U.S. Army, stationed in Germany, and spent my first few years of life there. Enjoyed myself tremendously, traveling all over Europe with my parents. Ended up coming back to the United States when my father finished his tour over there during the Vietnam War. He was stationed in Germany. He was a physician as well. So I ended up in California and grew up in California, Southern Cal, a place called Thousand Oaks, California. And between Thousand Oaks, Los Angeles, and San Diego, that's where I did most of my education. UC San Diego for college, university, and USC Medical School in Los Angeles for med school. Ended up matching at the top program in neurosurgery in the United States at the time for neurosurgical training in Gainesville, Florida, under the direction of Dr. Albert Roten. And some of my attending neurosurgeons were Dr. Arthur Day, Bill Friedman, Parker Mickle, Jeff Henn, Glenn Rectine. I'm going to leave out Pat Jacob because he was truly an abomination of human condition. Honestly think that he is really not worth even mentioning, except that he was just such a evil, malicious person. A couple of the other attendings were pretty bad. And then, of course, Steve Roper, who was my mentor during my fellowship and my NIH grant years, where I received funding from the NIH as a principal investigator for 2 years to do basically study something called cortical dysplasia, which is one of the causes of epilepsy. It's where the neurons and supporting cells don't migrate out in proper numbers to their proper locations within the cerebral cortex. So I spent 2 years in the lab working on rat brains, studying cortical dysplasia. I actually have a publication as a result of that work with Steve Roper and Michael King and Carla Kuda, who was an undergraduate at the time, interested in medicine. And finished at UF in Gainesville, ended up coming to Brevard County, Florida right away after I graduated in 2004. And I've been practicing in Brevard County here since 2004. So it's 2019 now. And we have the Deuk Spine Institute. This facility we're currently in is 20,000 square foot building with 12,000 square foot surgery center, which is AAHC accredited, Medicare certified, and licensed by ACA in the state of Florida. It's pretty much everything you could possibly do with a surgery center. And then we have a medical office building, which is part of the same surgery center building, so everything is in one location. We have our own MRI scanner here, x-ray machines, fluoro, ultrasound, pretty much all the diagnostic modalities you need in orthopedics and spine. And we're pretty much self-contained. That way we don't rely on any outside sources or influences. We can do everything ourselves here the right way for the patient. So that's always been my vision. The only thing we have to do out of the building right now is therapy. We don't have physiotherapy here. We refer to a group that does a phenomenal job with our patients. They're located 2 buildings down. So we're pretty much have everything you need except for pain pills, which we don't carry here, and physiotherapy. But obviously those are close by. So the surgery we just watched was a Deuk laser disc repair, lumbar for back pain, and left leg pain. And this patient has been suffering for many years. He lives in North Carolina with his family. They found us on the internet after he had already undergone several surgeries, I think 3 or 4 surgeries, unsuccessful for his back, still in pain. Nobody addressed the problem, which was his herniated discs and annular tears at L23, L34, L45. We know that because we did a discogram in the operating room, and it showed that L23, L34, L45 had tears, but also they were painful. And 2 of the discs were 10 out of 10 pain, which he's described as concordant, meaning it's his typical daily pain where he gets in his lower back. The other disc was also concordant, but it was 8 out of 10 pain. So I feel really good about the surgery. I think he's basically cured for his discogenic back pain for the first time in his life, despite having many, many, many procedures, shots, therapy, pills, surgeries, spinal cord stimulator. None of those worked. And I think we've got it now to where he's going to be very happy. It just took one surgery, really, just the right surgery, the Deuk laser disc repair for the herniated disc. We also got a spinal cord stimulator out because he didn't want it anymore. He wanted it out. It was bothering him. He said it wasn't working and it was bothering him, so we took it out. At this point, I'll answer questions from the audience, and I think we're going to have an opportunity, hopefully today, to see our patient leave in about an hour from now, in which case I think he's going to be basically out of pain. So we'll find out. All right, first question there, Zach. What do you got?
What does a T2 signal in the spinal cord mean?
What does a T2 signal in a spinal cord mean on MRI? So the only way to find a T2 signal is on an MRI. You can't see it on an X-ray or CAT scan. T2 signal increase means that there's water or edema. We call it edema or water or swelling inside the spinal cord. They're all the same thing. So T2 signal within the spinal cord indicates that the fat of the myelin from the covering the nerves that run down the spinal cord, we call those axons, all that fat is gone in that area and it's been replaced by water. So that happens when there's an injury to the spinal cord. And the injuries could be from a trauma where there's something that compresses the spinal cord suddenly, rapidly, severely, causes damage to the axons, which is then replaced by water, which you see as increased T2 signal on a T2 weighted MRI, or it would be dark on a T1 weighted MRI. So trauma is one reason. The other is inflammatory. So if you have multiple sclerosis or you have transverse myelitis, those are inflammatory problems, not traumatic problems that cause T2 signal increase on an MRI scan. So there's also tumors that can cause T2 signal increase, and vascular malformations can cause T2 signal increase. So T2 signal increase in an MRI in the spinal cord is very nonspecific. It could be many different things. You need to see a neurosurgeon to have it evaluated. A neurosurgeon is the only doctor that is proper, or a neurologist, to evaluate T2 signal change. Do not go to an orthopedic surgeon. It is not in their purview. Next question.
I recently had a stimulator put in, said it would help with my neuropathy, but it's not doing the trick, and I'm having back problems as well that we're supposed to help with. It has not. What should I do?
So we have a person watching who has a stimulator, a spinal cord stimulator in, and it's really not giving them the relief they were hoping for or they expected. What should they do? Well, here's really the diagnostic algorithm to determine whether or not we can help you. So neuropathy is a condition where nerves are damaged permanently, irreversibly, same thing as permanently. And the key is that when you have neuropathy symptoms, okay, so let's first understand that neuropathy is damage to fine little nerves in the hands or feet. Damage to those nerves and the diagnosis of neuropathy does not mean you will have symptoms from neuropathy. It's very important, okay? Very, very, very important to understand the difference. So lots of people have neuropathy but no symptoms. They have no numbness, no tingling, no pain, no nothing. They're normal. If you ask them, do you have numbness in your hands? Nope. So at some point, the neuropathy will get bad enough that the patient will notice symptoms, or the doctor will find things on exam that are related to neuropathy. So how can you determine whether the symptoms you're having right now are related to neuropathy or are they due to something else that could be causing similar symptoms. This is where most doctors get confused. They have no clue. They don't know what they're doing. And guess who pays the price? You, the patient, pay the price. You, the patient, will always pay the price for every failure in medicine, whether it's your surgeon or doctor that fails you by not making the right diagnosis or not giving you the right treatment or not referring you to the right place for treatment, or whether it's your politicians that are failing you by not making the insurance companies pay for the medically necessary care that you need, or whether the hospitals fail you by not negotiating good contracts with insurance companies, therefore losing money and going out of business and closing their doors. It's happening all the time. Or Donald Trump fails you because he fails to give you the right solution for health care. By the way, I'm a Trump supporter, but I'm not sure I agree with his health care policies because he's being led down a blind path by the insurance lobby, and he thinks he's doing what's right for the American people. I truly believe he wants to do what's right, but he's like, you know, when somebody's confused about how to solve a problem, that's what I would consider Donald Trump to be right now with healthcare. There's probably other things too, but I'm not going to comment on those. So I'm really focused on healthcare at this point, and I will comment to you about my understanding of healthcare. And I will tell you, whether you choose to believe this or not, or you think I'm arrogant or haughty or whatever, it doesn't matter to me. I really don't care about your opinion. The fact of the matter is that I know a lot about healthcare, and I know a lot about all the problems that we're having in healthcare. And people fight with me online all the time, and they're absolutely clueless about what's going on. So how could I possibly be clueful? Well, number one, I run a surgery center, which is basically a small hospital. Number two, I run a multi-specialty medical group practice, which is basically a group practice with lots of doctors, and I manage them. And I manage all the billing and collections, and I know exactly where the problems are in healthcare today. All right? And on top of that, I'm the former president of the medical society, which means I got to deal with all the issues that a medical society deals with. All the patient-related issues, hospital-related issues, insurance company-related issues. Oh, by the way, I was the chief of staff at the hospital for 2 years consecutively, which means I basically was the doctor who helped the administration run the hospital. Oh, by the way, I was chief of the surgery department as well. And the list goes on and on. So if you're wondering, am I qualified to make these statements? I am, 100%. I'm probably one of the most qualified people in the United States to make these statements because I understand the key issues affecting healthcare today. So when I comment on these things, it's because I feel very confident what I'm telling you is the truth. And I won't talk about things that I don't believe I have a very good understanding in. So that's why I don't care about other people's opinions that disagree with me, because I know they're wrong. And at that point, I know there are people who you can't change their mind, and I'm not here to change anybody's mind. I'm here just to inform people. Yes?
We're not sending the stimulator, right?
Clean the stimulator, put it in a bag, and give it to the patient. Why?
Well, you can't really clean it. And,
Then send it. Why not?
it's just extra bill. You got the X-ray documents at the end there.
That's fine. Thank you. All right. Sorry about that. I was talking to one of my staff. So, long story short, spinal cord stimulator person who's still in pain and suffering and has neuropathy. What I'm getting at with you is that your neuropathy probably exists, though I don't know for sure that it does. The only way to know for sure somebody has neuropathy, there's only one way in the world to know for sure, and it's called an EMG nerve conduction study. And that's where a qualified physician, not a chiropractor, not a primary care doc, but a qualified physician who's trained in electrodiagnostic medicine, that means they can do the EMG nerve conduction study, puts that machine on you, runs it, and finds neuropathy, okay? If that machine says you have neuropathy, then I believe it. So let's assume for a moment that that's been done, because I don't know who you are and I don't know if it's been done or not. But let's assume for a moment that it was done. So you have neuropathy. my next question for you is, and in my mind is, are the symptoms you're having in your legs due to neuropathy? Or are they due to something else? So it's entirely possible and likely, by the way, that the symptoms you're having are not due to neuropathy. And in which case, assigning them in your mind or the doctor's mind that's treating you to neuropathy would be a big mistake. A big, big, big mistake, and I see it happen all the time. Why is it important? Because, as I said before, neuropathy is irreversible and permanent. Symptoms from neuropathy are irreversible and permanent. You can't fix them. All you can do is cover them up, hopefully with some Lyrica or gabapentin or amitriptyline or a spinal cord stimulator. So that's why I need to discern or differentiate between your symptoms, which could be radiculopathy, or they could be neuropathy, or even it could be unrelated to the nerves altogether. It could be vascular. It could be dilated veins that have incompetent valves. And we call that venous hypertension. It causes actually tingling and burning in your calves and feet, particularly at night, and that's due to basically varicose veins. So there's a whole lot of causes of symptoms, and it's a good doctor's job to figure out what causes each patient's symptoms so they treat the right thing, okay? So what I would like to know from you is, with this neuropathy of yours, if the symptoms in your legs change during the day or night, do they ever change or fluctuate? Or are they absolutely solid, constant, no matter what time of day it is, no matter what you do? Because if they're rock solid, constant, and never change, and they're usually in your calves or your feet, like numbness or burning or tingling, then that's neuropathy, okay? On the other hand, if they come from your back and go down your leg and they come and go, that's radiculopathy. That's fixable. And that's why I need to know if your symptoms are constant and unchanging, or if they change with activity or what you're doing or how you're laying or sitting or standing. That's the first and most important thing I need to know. If you have fluctuating symptoms, then it is not from the neuropathy, and oh, good news, it's fixable. So what should you do? The first thing you should do is figure out if your symptoms you want addressed change, or are they static? Do they stay the same and never change? The second thing I would do is, since you can't have a MRI, you have a spinal cord stimulator, unless you have an MRI compatible one, I would like to look at an MRI or CAT scan of your back and do a video conference with you to figure out what's wrong and what can be done to fix you. So again, number one decision tree point is, do your symptoms fluctuate and change? Do they get better or worse with activities or position or standing, sitting, whatever? If the answer is yes, there's hope for you to get it fixed. If the answer is nope, they never change, then that's bad, and the spinal cord stimulator is going to be your best shot at fixing the problem. Now, the fact that it's not working may be due to a very important thing that happens with spinal cord stimulators. Is number one, is the programming proper? So did the person programming your stimulator do a good job? Believe it or not, you have to program those things. You have to run electricity from channel 1 to channel 4, or channel 2 to channel 6, whatever. And you got to adjust the frequency, the pulse width, and the amplitude. So if that's not done properly with your stimulator, then you're not going to be receiving the great benefit of the stimulator. So the programming is very, very, very important. Now, if you have a good programmer and they've done the best they can, and you're still not getting relief, then most likely what's happened is your paddle, your lead, whatever's stuck in your spine, it's moved. And if it moves, even a sonometer, it can throw off the benefit of the entire device. So the way you find that out is by getting an x-ray and seeing if the leads have moved. Your surgeon or doctor should be able to tell you that. So those are my thoughts on your condition. Next.
Will a discogram pinpoint specific nerves that are being compromised?
So someone asked, would a discogram pinpoint specific nerves that are being compromised? It's a very good question. So what is the discogram really good for? A discogram is really good to determine if a herniated disc is causing the patient's pain or not. So I'll say that again. The greatest benefit of a discogram is to determine whether or not a herniated disc is causing the patient's pain or not. And the way you do it is we use a discogram as a tool, a diagnostic tool, to determine whether or not a herniated disc is painful. So some of you might be thinking right now, well, aren't all herniated discs painful? Absolutely not. Only about 5% to 10% are painful. Well, why does that matter? It matters because surgeons and patients should only be operating on herniated discs that are painful. In other words, if I have a patient with 5 herniated discs in their back, L1, 2, L2, 3, L3, 4, L4, 5, L5, S1, every level is herniated. Do I want to operate on every level? No. You want to operate on only the herniated discs that are causing the patient's symptoms of pain in the back or leg, or neck and arm, for example. Do you want to operate on the other ones? No. You don't want to operate on an asymptomatic, meaning doesn't cause symptoms, herniated disc ever. Because if you did that, you'd be operating on every single person alive who doesn't, and they don't need the surgery. You see, the surgery can only do one thing. The surgery on the herniated disc can only take away back pain or neck pain. It can only take away arm or leg pain, numbness, weakness, and tingling. In other words, if a herniated disc is not causing back pain or neck pain, arm or leg pain, numbness, tingling, and weakness, there's no point in treating it at all, ever, until it becomes symptomatic. So the first thing we need to do as doctors is determine if your herniated discs are actually causing your symptoms, the patient's symptoms. And we have tricks to do that, but I can tell you this, 95% of the doctors out there don't have the tricks. They don't have the tool bag. You remember Felix the cat? All right, well, Felix had a little magical bag of tools and tricks. That's what we have at Deuk Spine Institute. We're able to determine where your pain is coming from in your back or neck because of our tools. And these are not like something you go to Walmart and buy off the shelf or go to Amazon and order. They will never, ever, ever be available at Amazon or Walmart or any other department store. They are skills that are learned, and they are tools and equipment that are acquired that have to be used together with skills in order to determine whether or not patients are suffering from a symptomatic disc herniation or facet pain or SI joint pain. So what I'm getting at is it's very complex. What you as a patient in 2019, 2020 should be thinking about is, how do I get somewhere where they can determine what's causing my pain and fix it? I don't know about other places because I haven't found any other place in all my searches and all my travels around the world that does literally even half as good a job as Deuk Spine Institute at making the diagnosis and doing the proper treatment. It's sad to say, but you wonder, why are we broadcasting? Why is this a live discussion with a neurosurgeon who specializes in spine? Why is this guy talking to us? Why is he on the air? Why is he teaching? Do I get paid to do this? Absolutely not. Every minute I spend teaching you all, I get $0 for it. So what do I get? Well, I get to educate. That's what I get to do. Educators like to educate people. They like to teach people. They like to share information, share their experience. And most importantly, a good educator wants to help someone get better. And that's exactly why I went to medicine. And that's why I've been doing education my whole life, from ever since high school and into college and medical school. I've always been a teacher of people. So I enjoy teaching. And I do it because I'm altruistic and I want to help people get better. I do it also because other people have helped me in my life when I needed help. They came and helped me, and they helped me without charging me, and they helped me graciously and kindly and patiently. So I'm here to help you. I'm here to return the favor. Call it karma, call it whatever you want. That's what Dr. Deuk Majan does these broadcasts for. Is there a corporation behind this? Absolutely not. It's me, 100% me. I am the 100% owner of Deuk Spine Institute. I share Surgery Center of Viera ownership with Dr. Patel and a few other people, namely my children and my wife. And I bring all of this to you listening for free because I want you all to be helped. I want you all to be better. I want literally to cure back and neck pain. And I want to be remembered as the guy who did it. So if you want to do anything, help the world remember that. The truth is we have found a way to cure back pain and we found a way to cure neck pain. And actually it's very similar. Back pain has a little bit more causes than neck pain. Neck pain only has like 3 or 4 causes. Back pain has double. So, you know, if you want to cure back pain, you have to look at certain structures, and we know what they are. And this whole business about fibromyalgia, I'll be honest with you, at 30,000 visits a year here at Deuk Spine Institute, 30,000 patient encounters a year, I see fibromyalgia once in 30,000. So what is fibromyalgia really? I think it's a real entity. I think it truly does exist. However, I think it's overdiagnosed. I think that most doctors who cannot figure out why people have pain in their back or neck, they just throw them into the fibromyalgia category as I don't know. It's probably just fibromyalgia. It can't be fixed. There's nothing for me to do. I'm safe. Whew. Thank God. No one's going to figure out that I'm incompetent. All right? So fibromyalgia, unfortunately, is being used by most doctors who can't figure out what's wrong with patients as an excuse for them not doing their job properly. It makes them feel good about themselves, and it makes the patients feel like, okay, I've done everything I can do. It's fibromyalgia. There's no cure. I'll just try to figure out what can be done for that. The truth is that 99% of back pain and 99% of neck pain is curable, 100% curable. It's just a matter of diagnosing the proper source. And that's what we do at Deuk Spine Institute better than anyone in the world. And I know that because I travel the world all the time. I meet with the best surgeons, the best doctors, and to my knowledge, there's nobody that does it better, not even close. And the reason I say that too is that it requires an interventional pain management doctor to stick needles in joints and inject numbing medicine to figure out if they're causing pain or not. And interventional pain management doctors are few and far between, and good ones are even rarer. So if there's 10,000 interventional pain management doctors in the United States alone, I would tell you that probably 100 are really good. So think about that. That means the vast majority of them suck at figuring out where pain is and fixing it. And that is absolutely the truth. They really do. I'm sorry. I'm not here to make you feel good about how I talk about other people. I'm here to tell you the absolute truth. Again, I'm not being paid by anyone. I'm actually footing the bill for this myself. So I get to tell you the truth if I want to tell you the truth. So why do I tell you people this? Because I like sounding like a mean person? No. It's because I truly believe you will not find a solution to your problem unless you know the truth. So I believe it all starts with being honest with people and telling them the absolute truth. So everything I tell you is the truth. It's based on my experiences in this field of spine for the last 20 years. And trust me, I push the envelope. I know what the system has, what it doesn't have available to help you. Okay? And I know who the really good interventional pain management doctors are. I go to meetings, I listen to them talk. I can listen to the other ones. I see their notes, I see their treatment, I see their failures. I see their successes when they happen. So what I'm trying to tell you is a big part of the problem in America and the world, and the reason why there's so many people with back and neck problems, is because we're not treating these patients properly. We're not diagnosing them properly, and we're not technically doing their treatments properly. And it's a big problem, and I want you all to be aware of that. I don't want you to think falsely that, oh, I went and saw an interventionalist and they said I need to do this, this, and this, and oh, I got to live with the pain because it's not fixable. No, the interventionalist just didn't do their job properly. And by the way, as a neurosurgeon, which I am, There's a lot of things that I don't treat personally as a neurosurgeon. I send my patients to the expert, the interventionalist, the chiropractor, the physiotherapist, the massage therapist. They're all very, very important. Now, you don't hear most neurosurgeons talk about that, and that's because they don't care about pain. They just care about compression, meaning something's pinching the spinal cord, something's pinching a nerve, and they want to go and unpinch those spinal cord and nerve. But when the patients have pain afterwards, they're like, hey, it's not my problem. Let's call pain management. Let's call pain service. And then you got the docs that come in that just write pills, or you got the docs that come in that just want to stick needles and they don't want to actually fix the patient. So we have a lot of those doctors, unfortunately, and that's why I'm trying to tell you the system's broken. So the first thing you need to understand is if you want to get better, you need to really take charge of your own care. Don't rely on your primary care doctor. Don't rely on your interventionalist. Don't rely on your orthopedic surgeon. Don't rely on your neurosurgeon. Rely on yourself. And that's why we do these broadcasts, is so that you can become educated about the truth, so you can get better. You can seek help in the right place. Okay? So I can't teach you everything I know in the short talks, but I can give you a little bit each time, and sometimes there'll be some repetitive redundancy. Hopefully the key points will stick. All right, let's get back to our question. What's next, Zach?
I've had 2 surgeries on my L5-S1 herniated disc, still having pain across my hips, and the doctors won't do anything else. What can I do?
So we have an observer, somebody who's participating here with us, who says, I've had 2 surgeries at L5-S1. I still have horrible pain. It's across my back and into my hips. The doctors that did the surgery say there's nothing else that can be done. Is there really nothing else that can be done, or can I be fixed? The answer is you can be fixed. No problem. Again, the reason your doctors are failing is because they haven't made the right diagnosis and or they don't have the right treatment available. Okay? That's why your doctors are failing to fix you. It's not because you have an unfixable problem, though they would love for you to believe that because you leave them alone and go somewhere else. So it's very, 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 very common scenario where I hear all the time people who say, my doctors say I can't be fixed. They've done everything that can be done. There's no need for any more treatment. Malarkey. If you're having pain, there's a problem. And if there's a problem, it's fixable. But you got to figure out what's causing the problem. Okay? So what I would recommend you do is quite simply, if you can come in to Deuk Spine Institute, we're located in Florida, fly into Orlando, drive to us. We're an hour away. We're right where NASA launches. We used to launch the space shuttle. We're right here in the Space Coast of Florida where SpaceX launches, where all the rockets and satellites launch from. Space Coast. Come into Deuk Spine Institute. Let me see you, examine you, and figure out what's wrong. Okay? If you can't do that, or you want to just figure it out over the phone, we can do that too. We offer a free MRI review, no obligation. I personally review every MRI. Dr. Deuk Major reviews every MRI. I try to figure out what's wrong based on the MRI, based on the history, and based on a physical exam. That physical we do over the internet. We do it through, what is that thing called? Skype. So we use Skype. So we do a video chat. I can look at your body through the camera. I can see where your pain's coming from. So I can do kind of an exam over Skype. And I combine that with your MRI that you already sent in. I'm usually about 90% accurate at getting the diagnosis based on Skype plus MRI. So if you can do that, happy to do it. Again, zero obligation, zero cost to you. We're like Wikipedia. We give you so much for nothing. Why? I don't know why Wikipedia does it, but my goal is to cure all people's back and neck pain in the world. It's a crazy goal. I'll never be able to do it. Not in my lifetime, but I'm going to sure try doing it. So I want to help everybody I can. That's why we do this. And we do it for free. All right, next.
My symptoms get worse as the day wears on. I'm assuming it's due to the disc height lessening and more interference from the annular tear on the compressed nerve. If you do the surgery in the morning and the disc height is optimal, how do you know you've removed enough interference?
Well, so it's a good question. I haven't had this question before, but somebody astutely says, you know, I have an annular tear, herniated disc, and the symptoms change through the day. So if I'm standing up for a long period of time during the day, I get more pain because I assume that standing for long periods of time puts a lot of pressure down on the jelly, squeezes it out so that it's further out into the tear, causing pain. And if you do your surgery on me in the morning, well, you know, I wouldn't have been on my feet all day, so the jelly won't be squeezed out as much, so the pain won't be as bad, but neither will the problem won't be as obvious to you, right, Dr. Deuk? The answer is no. I'm not laughing at your question. I'm laughing at the notion. But no, absolutely not a problem. The herniation is still there even in the morning when you're not having much pain. The difference is, think about it as the herniation is still there, but it's just not as full of pressure. And when you get up and walk around all day, what's happening is you're tearing up some of that scar tissue that surrounds the herniation, and that tearing of the scar tissue causes more inflammation, and that causes an aggravation of the pain. On top of that, you're probably getting some muscle spasms as well, because the disc pain will cause muscle spasms secondary, and then you're also probably getting some facet type pain as well, with the facet joints subluxing, because when the disc collapses, the facets slide down a little bit, and they can cause pain as well. So I don't know why. I don't know what's causing exactly your pain, but in general, I've been doing these surgeries 13 years. We always start in the morning, and the patients who have surgery first thing in the morning, they do as well or better than the ones in the afternoon, because there's fewer in the afternoon. So I don't really believe that the time on your feet and compression of the disc with extrusion, further extrusion in the afternoon is really a factor for having a successful outcome and a successful surgery. Because really, if there's any difference at all, it's probably, if you had to guess, it would be about the size of 10 glitter flecks. All right, next question.
Can already damaged nerves continue to worsen over time after a discectomy?
So the question is, can already damaged nerves continue to worsen over time after a discectomy? All right, great question. Another brain tickler. So the nerve is already damaged. You had a discectomy. Can it get worse over time? The answer is 100% yes. 100% yes. Very common. Why is that? Well, it's complicated, and I'm going to do my best to explain it. But there's not one answer. There's actually several. So first of all, let's say you had the discectomy and it was done perfect. That means the disc is no longer pinching the nerve. Well, number one, you could have a recurrent disc herniation. You know, whether it's a day later, or a week later, or a month later. More jelly can squeeze out of the hole if you don't avoid certain activities like bending and lifting. So you can have recurrent disc herniation causing more nerve damage. You could also have bony spinal stenosis, which means you remove the herniation, but now bone spurs from the facet joint squeeze in successfully. You can actually have your segment where your nerve is coming out there and the disc was taken out, the herniation was taken out, you can have it collapse and slide. So you can get sliding forward, called spondylolisthesis, which will pinch the nerve. You can have rotation or lateral sliding, which will pinch the nerve. You can have narrowing of the neural foramen through extension or subluxation of the facet joints, which will compress the nerve as well. And then, of course, there's a whole bunch of reasons why after a discectomy you would still have nerve symptoms, and mostly they're related to the other levels, you know, and or the same level depending on what's going on. But there's more than one cause of that. You need an MRI scan, and I could look at your MRI and I could tell if there's another herniation or if it's narrow where the nerves go out due to the facet or a facet cyst or facet arthropathy, hypertrophy, facet capsule hypertrophy. There could be inflammation as well in the neuroforamen on the nerve. There's so many reasons, and the fact of the matter is you got to look for all of them, and your surgeon needs to. If they don't know what they are, he's not going to look, and that's usually the case. Next question. By the way, great questions, everyone. Very insightful. Really, really good questions. It shows a very high level of understanding of the issues.
I'm a chiro with a patient who has sustained a disc protrusion.
What was that again? Start again.
I'm a chiro with a patient who sustained a disc protrusion.
Oh, okay.
It impinged on the L5 nerve. Within 6 months, had severe wasting of left glute and hamstring muscles. Testing was grade 1 or low 2. He underwent spinal decompression surgery and only regained strength to a +3 or maybe 4 after 5 months of exercises by both myself and a physio. What more can we do, or who is an appropriate referral?
All right, so we have a chiropractor, a doctor, asking a question about a patient of theirs, which is a really good question, by the way. And just to frame it, they have a patient with a herniated disc, I believe at L5S1, with such severe nerve compression by the herniation that they've developed atrophy in the gluteus and the hamstring. What did it say?
Yeah, glute and hamstring muscles.
So glute and hamstring. And they've done decompressive surgery, and they have the doctor has done treatment for 5 or 6 months with minimal to no improvement in the atrophy. What else can be done? So a couple of thoughts. First of all, the L5-S1 extrusion should compress the L5 or S1 nerve root. That would be your gastrocs or your tibialis anterior muscle, not the hamstring. So the fact that the hamstring is atrophic and the buttock is atrophic is concerning that we may not be at the right nerve. So that would be the first thing I want to know is, are we dealing with the proper nerve at L5-S1? I don't think so. So I think you need to look at L3-4, L4-5. Now, could there be a herniation at L3-4, L4-5? Yes. It could be a foraminal herniation that was missed by the radiologist. As a matter of fact, that's one of the most common things that are missed by the radiologist on looking at the MRI of the lumbar spine is a foraminal herniation. So does this patient have a herniation in the neuroforamen at L3-4, L4-5? That would be one thing that I would definitely go back and look at. Second of all, I would get an EMG nerve conduction study of that leg. I would want to know which nerve roots are affected. Okay? So an EMG nerve conduction study is where you connect the patient leg through wires to a computer that runs these specific tests to look and see what nerve roots are affected. If your nerve test shows only the L5 or S1 nerve root is affected, then that would support that the L5-S1 herniation was the cause of the atrophy to begin with. They're just patients wired a little different, which is fine. So let's assume then for a moment that this patient only had one disc herniation, L5-S1, and that was the cause of their atrophy. Because there's, in my mind right now, that L5-S1 herniation did not cause their atrophy, that there was a missed diagnosis and that the herniation is actually higher up at L3-4, L4-5 and probably foraminal. So let's assume though for a moment that the right diagnosis was made and the right surgery was performed. Well, let's just start with the right diagnosis. So let's say that there is no other herniation, there is no other nerve compression anywhere else except there was at L5-S1. And the surgeon, now we got to look at the surgery. Was the right decompression done? Was it done properly? Was all the herniation taken out? So here are a couple of things that happen in surgery that are bad, that could explain why your patient still has basically atrophy. Number one, the surgeon may not have gotten all the herniation out. Very common. Very, very common. Surgeons are humans. They make mistakes. They screw up. Okay, that happens a lot, not with me, but with other surgeons. I see it quite often, unfortunately. So the surgeon could operate on the wrong level. The surgeon could have left the herniation in accidentally, just by not being thorough or careful enough. The surgeon could also damage the nerve while they're in there. That's a possibility. They could accidentally damage the nerve, because remember, the nerve is already being stretched pretty badly with a large herniation, and then if you try to stretch it a little more, you may actually cause permanent damage. So that's also a possibility. And then there's a possibility the surgeons operated on the wrong level. I think I mentioned that one. So as long as the surgeon did the proper level, did a really good decompression, and didn't injure the nerve while they were doing their surgery, the next thing is that we've got the right level, the right surgery, and they still have atrophy. So it could be that the nerve was just permanently damaged. So if the surgeon did a perfect job and the nerve is still atrophy and the nerve has not healed completely from surgery, it could be because the nerve was being crushed so badly by the surgeon, by the herniation, that it was never going to make a full recovery no matter what. So that's another possibility, is permanent nerve damage or chronic radiculopathy. This is what you can do for your patient, is send them to a neurologist or a physiatrist, someone who does really good EMG nerve conduction study, and they can determine if there's ongoing active denervation going on within the muscles, the hamstring and the gluteus. So they would basically do an EMG nerve conduction study again now on the hamstring and gluteus and see if there's active denervation. If there's no active denervation and there's only a chronic radiculopathy, then that supports the notion that the patient's nerve was just so badly crushed before surgery, that it's just bad luck, or bad timing or whatever, and that it's permanent. On the other hand, if there's active denervation going on, that means the nerve is still being compressed actively now, and it needs another surgery, proper surgery. So those are some of the possibilities. I will tell you this, atrophy is very difficult to correct. I usually tell patients, don't let it get to that point. Get it fixed before the nerve becomes permanently damaged and you have atrophy. So those are just a few considerations for you. Good luck with your patient. I would be happy to see them if you want to send them here to Deuk Spine Institute. Deuk Spine Institute's happy to take any patient that's even been treated elsewhere. I don't throw other doctors under the bus. I don't criticize other doctors for doing things, perhaps wrong. I basically just stay very positive with the patient. I let them know they have a fixable problem if they do, and then I'm going to get them started and moving in the right direction to get fixed. I just really avoid, criticizing other doctors if possible. I criticize them here with you, talking to everybody now, but I don't criticize a patient's doctor specifically for doing a really bad job if they did. Some patients want to know. They're like, well, should my doctor have done this different? And I say, well, I would have done it different, and I think that's fine. But I try not to throw anybody under the bus directly with the patient. I don't mind throwing them under the bus later on when I'm talking to you about the truth of what happens in healthcare and spine care, because I think everyone needs to know. So I don't want my patients to hate their doctors that have treated them in the past. I just want them to be positive and move forward and get fixed. But I do want all of you here listening to me right now to understand that there's a lot of doctors that do things wrong. You have to find the right doctor to fix your back or neck. Was that our last question? All right, well, hopefully you've enjoyed this broadcast and learned something. I'm Dr. Ara Deukmajian, CEO and founder of Deuk Spine Institute, and we welcome your input. We welcome your participation in our broadcasts. These are designed to be educational. They're all streamed live on the day of surgery, and that way I can answer questions while I'm operating and caring for the patient. So thank you for your participation.